screen, just let me know whether it's visible, everything is clear. Is it visible?
Yes, sir, it's visible.
Yeah, just a minute. This is a different presentation. Yes. So, yeah. Good evening, everyone. As everyone knows, we started this Vertigo Talk series during the pandemic, and we are continuing. Almost 13 lectures we have done, and we will plan to continue every monthly. There will be hiccups in between, but I have decided that let us continue this activity. I personally like this activity because whatever interesting cases I see in that particular month, I can present in this forum. I'm very thankful to Dr. Sriharsha for that. And this particular presentation, we had it last time, in which I discussed uh, the central vestibular disorder. The major focus of this presentation was central vestibular disorders. And so in that lecture last time, I have posted the link of my last talk. For those who couldn't attend last time, I have posted that YouTube presentation link in the chat. uh, so this thing we have covered last time. I divided the central vestibular disorders into various categories, like central vestibular disorders based on etiology, based on clinical syndrome, based on prevalence, based on triggers, based on associated symptoms. So, how to identify central vestibular disorders based on these various clinical parameters that we were discussing first, and then I'm going to start the signs, various neurological signs, neurotological signs which I found in my patients. So, for that part one, you can refer to at leisure that another link. And let us continue that lecture with the clinical syndrome. The second part of the talk is based on clinical syndrome, how we can divide the central vestibular disorders. So, as we know that the common presentation of vestibular syndrome, there are three typical patterns in which the syndromes can present. The first one is episodic vestibular syndrome, in which the patient has a vertigo of finite duration. The vestibular symptoms are of finite duration. Patient is normal in between the attacks. This history taking is very important, because many a times patient think that if you ask them, they will tell that, oh, I am suffering from today morning. But if you go into the details, then patient, if you ask specifically whether that particular symptom lasted for some time and you got better and then it started again, is it happening in attacks, then the patient will come up with the history. So asking this particular question is very important. Then we know that patients can present with acute vestibular syndrome, that is vertigo, vestibular symptoms of continuously the symptoms are present, associated with nausea, vomiting, head motion intolerance. It could be either central or peripheral, and we are going to see how to differentiate that clinically, like symptom wise also and science wise. And chronic vestibular syndrome, in which the vestibular symptoms are typically more than 3 months in duration. The patient is suffering, and at least 15 days in a month patient has vestibular symptoms. So most of the patient have symptoms on a daily basis. So each of these syndrome, I honestly can be divided into triggered and spontaneous. But specifically, this triggered and spontaneous thing is applicable to episodic vestibular syndrome, which in which the patient can either have triggered episodic vestibular syndrome or spontaneous episodic vestibular syndrome. So in this now, Triggered episodic vestibular syndrome, now we have divided the vestibular syndromes into four parts. So these are the common central causes, and these are the common peripheral causes, and these are some other or functional causes. And let us see how these causes are they fit into these syndromes. So if we look at triggered episodic vestibular syndrome, we know that VPPV is the most common cause of positionally triggered attacks of vertigo. Then the second most common cause of triggered episodic vestibular syndrome is vestibular migraine, which can mimic like BPPV. It is very common to see vestibular migraine mimicking like that. Then the other triggered episodic vestibular syndrome, pressure induced, sound induced, are perilimb fistula, superior canal dehiscence. Even in case of vestibular paroxysmia, usually the patients will have spontaneous episodic vestibular syndrome, but the patients can still have the triggered attacks, like after changing the position. Typically, the patient can have stereotypical attacks. Then patients with spontaneous episodic vestibular syndrome, there are differential diagnoses. Again, is vestibular migraine, Meniere's disease. These are the two most common differentials apart from the transient ischemic attacks, vestibular paroxysmia, autoimmune inner ear disease, persistent postural perceptual dizziness. Ideally, it presents with a chronic vestibular syndrome, but patients can have fluctuating symptoms. Patient can have short-lasting symptoms in certain situations, and so it is very important to consider this as a differential diagnosis in this. Then comes the acute vestibular syndrome, where we have to consider a posterior circulation stroke before diagnosing a patient with acute unilateral vestibulopathy or vestibular neuritis. Even vestibular migraine patients can present with acute onset vertigo lasting for hours. You can see the patient during the attack, and it can mimic like acute vestibular syndrome. Pseudoneuritic presentation in demyelination, that is acute attack of demyelination, which is involving the brainstem, pontomedullary junction, is very common. Labyrinthitis, autoimmune inner ear disease, Ramsay-Hunt syndrome. So these are the causes of acute vestibular syndrome. Next is chronic vestibular syndrome, in which the most common differential is persistent postural perceptual dizziness. Vestibular migraine patients again can have, if they are untreated, they develop vestibulopathy, recurrent vestibular symptoms. Patients can go on to develop bilateral, even bilateral vestibulopathy like presentation is common in vestibular migraine, although rare. Posterior fossa tumors, neurodegenerative disorders, Arnold-Chiari malformation, medication usage. Bilateral vestibulopathy should be considered as a differential diagnosis in chronic vestibular syndrome. Even the Priss bivestibulopathy is one of the very common entity which is seen in elderly patients, which should be considered. Now, let us take out the all the peripheral causes, because peripheral causes are something which this motto of this particular talk is central vestibular disorders, where we are going to focus. So if we look at the most common central disorder is vestibular migraine, and it can present like any syndrome: triggered vestibular syndrome, spontaneous episodic vestibular syndrome, acute vestibular syndrome, or chronic vestibular syndrome. The most common presentation is spontaneous. They can have additionally triggered component like positionally triggered component, head motion induced dizziness. During acute attack, the patient can present with this acute vestibular syndrome. Then comes the posterior circulation stroke, is very important thing to be uh, thought of. That is vascular vertigo. Vascular cause of vertigo should be considered in a patient with acute vestibular syndrome. Demyelination is another central cause. Transient ischemic attack, which comes in the spectrum of vascular vertigo. Posterior fossa tumors can present with vestibular syndromes. Neurodegenerative disorders, Arnold-Chiari malformation. These are common differential. Even there are other differentials like thiamine deficiency, with vitamin B12 deficiency. Episodic ataxia type 2 is can present like migraine. but the patients have some typical features, and patients can have ataxia, episodic ataxia they can present with. Paroxysmal brainstem attacks can happen in patients with past history of stroke or past history of demyelination. The patients can have paroxysmal brainstem attacks. I have some cases. If time permits, I'll present that. Then this vertebral artery compression syndrome, the name is now changed to brainstem vascular compression. Because this particular name is given to the rotational vertebral artery syndrome is now called as vertebral artery compression syndrome. That is also a central syndrome. Then comes the room tilt illusion, which can be seen in patients with lateral medullary infarcts. Vestibular epilepsy is a little rare, but it can happen, especially in children. The patients can have vertigo as an aura symptom before the actual seizure. So these are the this is the spectrum of vestibular central vestibular disorder. Last time we have discussed based on the etiology. This was about according to the clinical syndrome. Now next is based on triggers, like what is the trigger for the symptoms. So first is symptoms majority of the times in central disorders. The symptoms are present even at rest. For example, in case of acute central vestibular syndrome, like in a patient with vascular vertigo, it develops spontaneously. The stroke develops spontaneously. And vestibular migraine, patients can have spontaneous attacks of vertigo. But although this is the common presentation, but we have to remember one thing, that the central positional vertigo uh, is one diagnostic entity, and central causes of vertigo can present like a positional vertigo, can present like BPPV. The vestibular migraine can present like BPPV. Strokes can present like positional vertigo. Demyelination can present like positional vertigo. There are certain degenerative disorders like CV junction anomalies, for example, or multisystem atrophy. It is a Parkinsonian disorder. The patient can have positional nystagmus than vertigo. So these are the differential diagnosis we should remember, and we should always keep this in mind. If we find any atypical features in the BPPV, it is very important to think about these disorders. So what are the different causes of central positional vertigo? One most common is vestibular migraine. Other causes are not only cerebellar, but even brainstem causes, infarctions, demyelination, tumors, degeneration can lead to central positional vertigo. Now, just to just to present one case of central positional vertigo, I had seen a patient who presented with positional vertigo, and there were other symptoms also. But typically when I did the positional maneuver, there was no latency. The nystagmus started immediately. There was no fatigability. So, yeah, for example, even if the position is maintained in that particular position, disulfide, the it was not fatigable. But you have to remember one thing is that the central signs, all the central signs may not be seen in a particular case. One particular red flag might be there. For example, one another patient I have seen where the patient didn't have latency, but it was fatigable. Like it was getting fatigued after a minute. The nystagmus was getting fatigued. There was no rebound, but there was no habituation. Even if I repeat that disulfide testing again and again, it was not getting habituated, and intensity of vertigo was there. There was associated vertigo, but the intensity of vertigo was mild. But another important clinical clue here is if a patient has nystagmus, positional nystagmus, and doesn't have associated time lock symptoms, then please consider central vestibular disorders, because many a times, for example, in case of multisystem atrophy, the patient might have central positional nystagmus, but the patient may not have any symptoms. So nystagmus is not synonymous with the positional vertigo. The positional nystagmus, if it is present without any symptoms, think of central causes. Reproducibility is good in case of central. Directionality and waveforms are variable. For example, in patients with, if you try to differentiate BPPV from vestibular migraine, you will find that BPPV patients will have typically time-locked symptoms along with the nystagmus. But in case of this particular, in case of central positional vertigo or in case of vestibular migraine, the symptoms are not time-locked with the nystagmus. Even you might find a nystagmus of posterior canal variety or lateral canal variety, but it may not be. You might find discordancy between the nystagmus and discordancy between the symptoms. It may not be time locked. So these atypical features, you should start thinking about the central causes. So this is the patient I was talking about. I did Dix sulfide. Patient had right lateral medullary infarction, and I took him to the lying down position. As soon as I took him to the lying down position, he started getting this downbeating torsional nystagmus. I hope you can appreciate this. Depends on the internet speed and streaming. But the patient had downbeating nystagmus. You can clearly see the downbeats, and the patient had also a little torsional component also. So it can happen, but the most important clue is, if you do alone positional testing, you you will miss a lot of things. If a patient presents with positional vertigo and you do only positional testing, then it might happen that you might miss a patient with a stroke. But if you look for any symptoms which are in favor of central, for example, patient might be having hiccups, patient might have numbness over the face, numbness over the extremities. Patient might complain of little dysphagia, slurring of speech, little facial deviation, weakness of hands. So it's very important that if there are any red flags for the diagnosis of BPPV, they should be picked up in patients with positional vertigo. And even in case of signs, it is not alone positional vertigo or nystagmus. Usually these patients will have other signs. It will not happen that patient will have isolated positional vertigo and nystagmus in central case. Most of the times they will definitely have neurological signs, which are very important clues towards the central etiology. And I'm going to present similar cases like in this particular talk. So then comes the like central vestibular disorder based on associated symptoms. Just now I discussed about some of the associated symptoms like slurring of speech, dysphagia, double vision, numbness, severe postural instability. If the patient is not able to stand, not able to walk, unsupported, then it goes in favor of like central. But of course, on the first day of vestibular neuritis, the patients can have postural instability. Patient might come in wheelchair, but always it's a good idea to check for everything. It is not see what makes this field so interesting is there are caveats for everything. There is caveat for everything. So there are exceptions. So it is very important to know these exceptions, and accordingly it will help in the clinical diagnosis in that particular situation. So then the vascular risk factors should be considered, like diabetes, hypertension, dyslipidemia, obesity, smoking, high ABCD square score. So these are the vascular risk factors which favor a patient with a stroke. But it doesn't mean that if a patient comes with vascular risk factor and vertigo, every patient should be subjected for MRI. Of course, in elderly patient, BPPV is also common. So always it is very important to analyze. It is not one single factor alone. It is a combination of things which will make the diagnosis. For example, I'll tell you. Recently, I encountered with one patient. I have that case in the end, but if the time doesn't permit, I'll just tell about that patient. Uh, a patient presented with severe like imbalance of gait. Like he had imbalance of gait which lasted for 5 minutes. He was not able to walk properly, and he recovered. Then he came to me like on the same day, within 2 3 hours he came. His blood pressure was very high, around 220 to 220 by 110, and he didn't have blood pressure in the past, diabetes in the past. He had a very low ABCD square score, but ultimate that patient had that episodic imbalance with high blood pressure, which is acute phase reactant in a patient with stroke. I did imaging and patient had small infarction. Even though the patient clinically recovered, the patient had infarction in the brain. So it's very important. Ultimately, all these clues are important, but in a given case, it's important to correlate everything clinically. So this ABCD two score stands for A stands for age that is more than 60 gives 1 point. If the blood pressure is high, it gives if the blood pressure is more than 140 systolic and 90 diastolic, that is one more point. Unilateral weakness fetches 2 points. Speech disturbance is one. If the symptoms last for more than 60 minutes, it is 2 point, and 10 to 59 minutes, it is 1 point. Presence of diabetes is 1 point. So if we look at this particular scoring, if the score is high, that favors that the 90-day risk of the stroke, 90-day or 7-day or the 2-day risk of stroke is very high as compared to the lower score. But as I mentioned in my patient, the patient had only 1 point here, 1 point here, and the patient was absolutely normal, and the patient symptoms were lasted for 5 minutes only. This was zero, and even the patient was non-diabetic. So the score was only 2. So if he was in the low group, but still I could diagnose the stroke because as a stroke, because we have to correlate clinically. The blood pressure was very high. It will not go high, so high in a peripheral etiology in acute setting. So it's very important to pick up some diagnostic clues. When the patient came to me, he didn't have any sign. His only parameter was blood pressure was high. So we have to pick up these signs, and that will help in diagnosis. Now, coming to the vestibular migraine is one of the most common disorder which causes vertigo. It is one of the most common central vestibular disorder. Along with the vertigo, the patient may or may not have headache, photophobia, phonophobia, visual aura. It is not mandatory that they should have, but 50% of the episode they should have these symptoms. That is diagnostic criteria. That is what diagnostic criteria says, but in practice we see that many a times patients deny these symptoms, but still you can diagnose vestibular migraine and treat if there is other diagnoses are excluded. Now coming to the hearing loss and or tinnitus, these are the differential diagnoses for patients who present with hearing loss and or tinnitus along with vertigo. And the two central etiologies which should be considered are anterior inferior cerebellar artery infarction and demyelination. This demyelination in the dorsolateral pons. These are the two central things should be considered. And one thing I don't know, I forgot to mention is labyrinthine infarction. For example, we know about labyrinthitis. Inflammation of the labyrinth is labyrinthitis, or inflammation of the vestibular nerve is vestibular neuritis. But the patients can have isolated occlusion, embolism of the end artery which supplies the labyrinth, that is labyrinthine infarction, and it can totally mimic like labyrinthitis, a patient with labyrinthitis. So it's very important that to differentiate between this inflammatory versus this vascular etiology. Many a times these cases are treated as labyrinthitis, but later on what happens is after some time they present with another stroke, posterior circulation stroke. So that is the definitive evidence that this patient had vascular. Currently, there is no diagnostic modality which can differentiate between a vascular cause versus the inflammatory cause. There is less. There are certain clinical parameters which can help. There are a lot of there is a lot of research going on in this field, but labyrinthine infarction per se can present like a peripheral etiology. It can totally mimic a peripheral. So this is what I would like to emphasize is if a patient has a central sign, it is definitely central signs or symptoms. But if a patient has peripheral signs, it can still be central. It can be peripheral, but it can still be central. This is very important take home message I would like to give from this talk is if a patient has clear cut peripheral signs, still it could be central unless there are red flags. It is very important to find red flags in these patients, and there is no single sign which will help you to differentiate central or peripheral. Many times in conferences, this question is asked. Tell me one central one difference between central and peripheral causes. It is not like that because central nervous system is so huge. So different location the patient will have different type of symptoms and signs. So it's very important to correlate clinically and the to remember the various caveats in diagnosing peripheral and central causes. Now coming to the anterior inferior cerebellar artery infarction. If a patient has isolated labyrinthine artery infarction, it is difficult to differentiate. Then you have to rely on the blood pressure at the presentation. Then you have to rely on ABCD, high ABCD score, vascular risk factors. A lot of things you have to take into consideration. But if a patient has anterior inferior cerebellar artery infarction, there was one study which said that 96% patient had some or other central ocular motor or vestibular signs. So another take home message is whenever a patient presents with vertigo, it is the time to look into the eyes of the patient. It is very important to do a thorough ocular motor testing of the patient because we can pick up the stroke in a patient with the seemingly presenting like labyrinthitis, seemingly presenting like an acute attack of Meniere's disease. It's very important to check whether the patient has any other central ocular motor signs to differentiate it from like anterior inferior cerebellar artery infarction. So this is that article. 96% patient also had accompanying central ocular motor or vestibular signs that were characterized by asymmetrical smooth pursuit, optokinetic nystagmus, bidirectional gaze evoke nystagmus, abnormal modulation of the vestibulo-ocular reflex using visual inputs. And another important thing is, see, routine clinical examination may miss these things. For example, asymmetrical smooth pursuit. It is very difficult to judge the velocity of when the eyes go from right to left versus the left to right. It is very difficult to judge the velocity visually. But suppose you have video nystagmography, it is an extension of clinical examination. I'm going to show some cases where I could pick up the smooth pursuit was saccadic on one side as compared to the other side. So optokinetic, you can get asymmetry, the bidirectional gaze evoke nystagmus, and all these objectively you can pick up these nystagmus and ocular motor signs if you have video nystagmography. Now that was based on associated symptoms. Now based on prevalence, let us see. If we look at this particular study of around 35,000 patients, where German center, where Professor Stroop and Professor Thomas Brand, the group where they are practicing. This is a tertiary care center for vertigo, and as see the what happens is the spectrum of patients what you see in a in a different setups is different because for example I'm a neurologist, so the spectrum of patients which I see, I see more of a patients of vestibular migraine as compared to BPPV. if we compare between BPPV versus vestibular migraine, I see a lot of cases of vestibular migraine as compared to BPPV. But as opposed to my ENT colleagues, they see more cases of BPPV as compared to vestibular migraine. So it depends on the setup where you are practicing. And as the practice goes up, like for example, it becomes a tertiary care center, the patients with chronic vestibular syndromes will start coming up, and the functional causes of dizziness will be more predominant in your practice. So the day when you start seeing more patients with functional dizziness, this is another clue that your practice is going from primary to secondary and secondary to tertiary level. So this is what these are the common causes of like there are certain causes which are common in central. So I will mention the various causes in central. That is vestibular migraine is the most common. Vascular vertigo, that is a newer terminology which is given to the earlier we used to call vertebral insufficiency, vertebrobasilar insufficiency, or posterior circulation stroke. But uniform terminology what they have designed is vascular vertigo. If a vertigo is originating from a vascular cause, whether it is infarct or a bleed, it is called as vascular vertigo. Then comes the demyelination, tumors, nutritional deficiencies, CV junction anomalies, cerebellar degeneration. So these are the various causes we should consider in a patient who is suffering from vertigo, and these are the common central causes. Of course, there are many other causes. Now coming to the clinical pearls in diagnosing central vestibular disorder based on the history, based on the examination. So what I'm going to do now is first I will go into like various clinical pearls in diagnosing central vestibular disorder based on the examination, because examination it is fascinating. The various signs which are seen are fascinating. So of course there are certain historical points which are important. First I will show you cases of like various central signs which I have seen in my practice here. Uh, yes. Okay. So before going to that, I will just mention that as a clinician, we get uh, like pieces of information from the patient. These are various pieces of information we get from the patient. And what we have to do is we have to make out something from it. We have to basically like make something out of it, like whether it is a central disorder or a peripheral disorder. Why the localization is important is because you can accordingly like manage the patient. You can uh, decide the plan when to refer to a neurologist, when to refer to another like specialist. It can be decided like based on the localization. So, and it is very important to recognize the pattern, what pattern the patient has. Where patient has acute vestibular syndrome, episodic vestibular syndrome, the pattern recognition is very important, because what happens is there are some disorders which cause multiple types of vestibular symptoms. For example, I'll show you like vascular, as I was discussing, a patient with stroke can present with spontaneous vertigo, can present with positional vertigo, can present with unsteadiness, ataxias. Patient can present with ataxia, cerebellar ataxia. In spontaneous vertigo, the patient can have short lasting vertigo, patient can have vertigo lasting for hours, or the patient can have positional vertigo. So it's very important that there are certain to know that there are certain disorder which can cause multiple types of vestibular symptoms. Then there are some disorders which go into multiple syndromes. For example, a patient with stroke, the patient can fall. A patient with stroke, normally we know that patients with stroke present with acute vestibular syndrome, but the patient can present with acute spontaneous episodic vestibular syndrome. As I told just now, one patient, Patient had imbalance lasting for 5 minutes, and the patient, I did MRI, and patient was having infarction. It can't be called as TIA because once you see diffusion weighted restriction, it is called as stroke. Earlier, the definition was of TIA was reversible symptoms. But even if the patient has reversible symptom, the patient still has MRI showing the diffusion weighted restriction. It is called as stroke, even if the patient might have recovered from the symptoms. Then comes the triggered episodic vestibular syndrome, chronic vestibular syndrome. So patients with stroke later on they develop chronic vestibular syndrome because of the chronic ataxia they have. So a single disorder can fall into multiple syndromes. It is not that always a patient with stroke will present like acute vestibular syndrome. Then vestibular symptoms evolve over a period of time. This is very important to remember. In the same patient, the vestibular syndromes can evolve over time. For example, a patient has vestibular migraine and the patient presents with vertigo, spontaneous attacks of vertigo. The same patient, because of the suffering, can develop unsteadiness because of triple PD. Patient later on can develop the symptoms suggestive of agoraphobia, triple PD, and certain situations like supermarkets. The patient can become unsteady, and the patient can also develop dizziness, which is related to the anxiety and panic disorder in the same patient. So over a period of time, the patient can evolve. And vestibular migraine patients are again prone to develop BPPV. So patient can again, even patient presents with positional vertigo per se because of vestibular migraine or because of BPPV, which is more common in patients with vestibular migraine. So in the same patient, it is you can see like symptoms, vestibular symptoms evolving over a period of time. For example, you see a patient with vestibular neuritis. For 1 day, 2 day, 3 day, the patient has spinning vertigo, 1 or 2 days, and that goes into unsteadiness. That becomes as the patient, same patient starts telling that I feel dizzy, that they start feeling heaviness in the head, disorientation. Patient can clearly say that that spinning sensation has gone, but now I am feeling a little disoriented and I am feeling heaviness in the head. Then after a few days, the patient, if the same patient has developed severe anxiety during the acute stage, the same patient can present with triple PD symptoms like unsteadiness, fear of supermarket. So it's very important to remember that vestibular symptoms can evolve in the same patient. Then comes the there are some certain disorder which come together. For example, a patient with vestibular migraine can develop triple PD, can develop general anxiety disorder, generalized anxiety disorder, major depressive disorder. This is a very common mixture, or I can say cocktail, I find in my practice, where the same patient has anxiety, same patient has functional dizziness, a patient with vestibular migraine having anxiety, depression, functional disorder, functional cause dizziness. So it's very important to address all the three aspects. What are the three aspects of vestibular diagnosis? Structural or cellular diagnosis, functional diagnosis, and the psychiatric diagnosis. Unless we address all the three components of the diagnosis, the patient is not going to recover. If you say that, okay, I'm treating the patient's vestibular migraine by giving some beta blocker or giving some topiramate or some migraine prophylactic therapy, I have done my job. No, the patient will not recover. If you give a patient suffering from depression, if you give a topiramate, it will worsen his depression. If you give a same patient a flunarizine, it will worsen the patient depression. If you give beta blocker, it will worsen his depression. So the right choice of drug will be amitriptyline or venlafaxine or desvenlafaxine. So it's very important to recognize what are the associated disorders in the same patient. It is not that patient will always have single disorder. For example, I had one patient who she presents with BPPV, recurrent BPPV. First attack of BPPV, repositioned, she was okay. Second attack of BPPV, she repositioned, but she developed a lot of phobia and she started developing intermittent triple PD symptom. Third attack of BPPV, she developed like continuous that fluctuating sense of unsteadiness and developed triple PD. So patients can evolve symptoms over a period of time. The same patient can have other vestibular diagnoses also. For example, I had one patient. She presented with classical BPPV eye reposition, came back later on 2 months later, and it was a positional vertigo. I was trying to reposition, but I was not able to reposition. I did imaging, which was normal, and then she started complaining. She had a history of migraine in the past. I treated her for my as a case of vestibular migraine, and she recovered. So the same patient had one positional vertigo attack for because of BPPV. Another one was because of vestibular migraine, and the same patient had she developed triple PD symptoms later on. So this is very important that we have to remember this thing that vestibular diagnosis can happen. Different vestibular diagnosis can happen in the same patient. So this is the localization. I'm not going to go into the details of the peripheral ones, but the central ones we have to localize whether the which is the etiology. We very important to decide what is the etiology, what is the localization. There was a very nice algorithm we used to follow in case of neurology. Like for example, any neurological diagnosis we used to tell in four categories, four tiers. First is functional diagnosis. For example, a patient has hemiplegia. Functionally, the patient has hemiplegia. This functional is not equal to the routine functional what we talk about, the functional diagnosis, that is triple PD and all. This functional means functionally means when the patient is trying to function, then the patient notices weakness in the one side. Then the functional diagnosis is hemiplegia. Then comes the anatomical diagnosis. Anatomically, the patient physiologically corticospinal tract involvement is something which leads to the hemiplegia. Then the anatomical diagnosis we have to localize whether the corticospinal tract involvement is in the corona radiata, whether the corticospinal tract involvement is in the motor cortex, or it is in the internal capsule, or it is in the pons, or it is in the medulla, or it is in the cervical corticospinal tract. So this is third, that is tier, that is anatomical diagnosis. Fourth tier is etiological diagnosis. So there are four tiers in the neurological diagnosis. One is uh, this functional diagnosis. Second is physiological. Third is anatomical. Fourth is etiological. And in case of vestibular diagnosis, we just now we thought of one is structural or cellular diagnosis. Second is functional diagnosis. This functional is different. Like this is in relation to the patient having a perceptual component. And the third is psychiatric diagnosis. Unless we address the psychiatric component of the patient, patients are not going to feel better. Just treating their structural or cellular etiology is not complete treatment. For example, I had a patient with vestibular neuritis. I knew that it is neuritis. I treated him for neuritis, and I was telling him, "I have treated you. You can like no need to worry." But the patient was worrying too much because he developed anxiety disorder. He developed triple PD symptoms, and I honestly, it was 3 years ago. That time I was not. I was a very generic psychiatrist. I was not treating, giving that much importance to the anxiety symptoms. I just did his generic counseling, but it's very important to refer this patient to a psychiatrist and treat the anxiety component. Unless the patient feels all right, our goal cannot be achieved. Our goal is patient should feel better as a whole, not just treating just the original diagnosis, but what are the associated components also we have to treat it. Now, this is very important thing I would like to tell is, for example, as we see in our practice that there are variety of peripheral symptoms and variety of central symptoms. And there are symptoms which fall into both the categories. So if we look at the peripheral peripheral etiology, peripheral vestibular etiology, autophony and recruitment are the only symptoms which truly localize to the peripheral etiology when they are related to the auditory component. But if you look at the vestibular symptoms, you cannot say that if a patient is suffering from vertigo, okay, yes, it is peripheral. It is very difficult to say unless we look for other signs or symptoms which are purely seen in central etiology. So it's very important. I distinctly remember a patient who had vertigo, and because of the anxiety, he was not able to speak properly. Actually, he was so anxious that he was not able to. And I thought it is central, and I did MRI. It was normal. I kept him on antiplatelet for some days, and then I realized that okay, these sometimes these symptoms, even the so-called central symptoms, can also happen in patients who have severe anxiety. So it's very important to keep your mind open, and it's very important to remember that central signs are central. First thing you have to consider is central, but peripheral symptoms can be central or can be peripheral or can be central also. So there are three golden questions in a patient with acute vestibular syndrome. This is pertaining to acute vestibular syndrome because usually the most common central etiology we are worried about is a stroke. And the first thing which we have to see is, can the patient stand unassisted? Then the second question is the patient having hearing loss, acute onset hearing loss? It could be a labyrinthine infarction. It could be anterior inferior cerebellar artery infarction. So that's why it is very important. Then whether the patient has any other worrisome symptoms, that is dysarthria, dysphagia, diplopia, numbness, weakness, hiccups. So these symptoms are worrisome symptoms. Now let us go to the signs. These are the peripheral signs which we commonly see. These are the central signs which commonly see. And these are the common things. They can be seen in peripheral also, they can be seen in central also. So this is the group of things which can be seen in central as well as peripheral. Okay. So what happens is Tulio phenomenon and the Hennibert sign. These are the truly peripheral things. Okay, but if we look at the various signs, peripheral signs, for example, positional nystagmus we discussed. Positional nystagmus can still happen in patients with central. We have discussed that. Pathological hit, pathological head impulse test can happen in central etiologies. There are certain strategic locations in the brain where the patients can have pathological head impulse test. It is not that it is always a normal head impulse test. Then in a patient with stroke. Then comes the nystagmus without fixation. Nystagmus without fixation is a peripheral sign, but it can still be seen in central etiologies. It is not that it is all like only seen in peripheral. Nothing is there are only few signs which are exclusively seen in peripheral, but these are the Tullio and Hennibert's. But other signs, it is very important to look for any other central symptoms or central signs. Then comes the unidirectional nystagmus. Unidirectional nystagmus can also be seen in central etiologies. I have some cases which I am going to present. But the most important thing to remember in unidirectional nystagmus is it following Alexander's law? Alexander's law, only the peripheral vestibular nystagmus will follow, but it is not followed in central. So that is very important clue. And skew deviation, whenever you see a skew deviation, first thing what you should come in your mind is central. 30% of the patients with acute vestibular syndrome can have skew deviation if it is due to posterior circulation stroke. But on the first day of vestibular neuritis, you can still see skew deviation in some of the patients with vestibular neuritis. You can see. So that's why it is so important to know these caveats. Now, another caveat I will tell you. I will tell you in the next few slides. For example, in head impulse test, if you do head impulse test in out of context, for example, a patient presents with positional vertigo, and you do head impulse test, it is going to come normal, and if it comes normal, you can't label that patient as central etiology. So it is very important to do certain things in right context. If it is not done in the right context, it is going to you are going to land up central diagnosis in every patient. Every patient you will land up in central diagnosis. In a BPPV also you will think that okay, this pure torsional nystagmus is seen. Okay, this is central. No, it can be peripheral, because the central suppression mechanisms can suppress the other types of nystagmus, horizontal and vertical nystagmus, more than the torsional. So the torsional can look as a very predominant if you are checking the patient without removing the fixation. So it's very important to remember these caveats, and if the caveats you know, then it becomes easy, and then the false diagnosis of central in every patient can be avoided. Now, golden points in examination are: head impulse test must be done in a patient with acute vestibular syndrome. In right context, it should be done. For example, if a patient has ongoing vertigo, continuous vertigo, if the patient has head motion intolerance, nausea, vomiting, continuous vertigo, then it is the best candidate for doing the head impulse test. If a patient has positional vertigo, and the patient is normal in between the attacks, in that patient, head impulse test will definitely lead you to a central etiology. Then coming to the ocular motor deficits, the most important thing to see is the nystagmus. What variety of nystagmus the patient have? Again, there are caveats. For example, the classical gaze evoke nystagmus or direction changing nystagmus is: if you ask the patient to look to right, the patient has nystagmus. If you ask the patient to the left, he has nystagmus beating to the left. Right beating on the right gaze, left beating on the left gaze. That is direction changing nystagmus. Suppose a patient comes to you with positional vertigo and there is no gaze evoked nystagmus, and you do supine head roll test. On right, turning to right, the patient has right beating. Turning to the left, head to the left, the patient has left beating nystagmus. You cannot call that nystagmus as this direction changing nystagmus of central etiology. It is direction changing, but we are using a provocative maneuver. We are using a positional. We are changing the head position of the patient, and then only the patient is developing that type of nystagmus. So it is very important in what context we are saying what is very important. So that will decide which etiology it is, whether it is central or peripheral. Then this is a very important question, that is, does the nystagmus follow the Alexander's law? The peripheral nystagmus follows the Alexander law. The central nystagmus doesn't follow the Alexander's law. Eye alignment, the torsional skew. The test of skew is very important. As I discussed, sometimes it can be seen in peripheral, but by and large, we should think of central etiology. And again, test of skew, the patient having a skew deviation is a rare sign. It is not a very common sign, but it is seen. It is seen in patients with acute vestibular syndrome. We should be open enough to look for this sign, and we should not miss this sign. Even obviously it is present, it should not be missed. Then the next is, can the patient stand unassisted? Are there any other neurodeficits? So just you might have heard the alarm. That is, we have completed 1 hour, and anyway, we are going to have this particular series going on, and I have a lot of cases of central vestibular syndromes with all the signs: this skew deviation, gaze evoked nystagmus, pure torsional, head impulse positive in patients with stroke, like positional nystagmus in patients with stroke, pathological head impulse in stroke, variety of nystagmus, rebound nystagmus, seesaw nystagmus, convergence nystagmus. All these signs I'm going to present one by one. So this is the last slide of this particular this today's talk. But I'm going to continue this in the form of different clinical signs, and I'm going to focus in next series about only the central vestibular syndromes. So this particular clinical pearl is important. Central symptoms and signs are central in origin, and peripheral symptoms and signs can be peripheral or central. But again, there are caveats. Now, skew deviation is a hardcore central sign, but it can still be seen on the first day, few days in a patient with vestibular neuritis. Gaze yolk nystagmus is a hardcore central sign, but if suppose a patient has bilateral vestibulopathy, if you remove the fixation because of the left vestibulopathy, the patient will have right beating nystagmus on right gaze. And because of the right vestibulopathy, the patient might have the left beating. So the caveats you should be aware of. But this happens without fixation. Again, these things if we remember, then there will not be any confusion. For example, pure torsional nystagmus. Now, as I told, pure torsional nystagmus can be sometimes seen in peripheral variety. For example, a patient has common crus. When the otolith is traveling through the common crus, the upbeating component of the posterior canal and the downbeating component of the anterior canal can get cancelled, and the patient can have pure torsional. Or the second possibility is the patient, if you are just doing the positional testing without removing the fixation, without the Frenzel glasses, without the VNG flap, if you are doing it, the patient can still have, sometimes you can see that there is a torsional nystagmus, pure torsional, looking like a pure torsional. But once you remove the fixation, then you can see the mild upbeating component or downbeating component can be missed in these patients. So you can label this patient as central, but it can still be a peripheral. Now, as I told, the head impulse test, if you do it out of context, if you in a patient with BPPV, positional vertigo, if we do head impulse test, it is going to come normal, and out of context, we can call it as it can be labeled as a central. Now, let us see, there are certain peripheral signs which are seen in central. For example, a positional nystagmus. By and large, we know that positional nystagmus is seen in peripheral, but it can be seen in central etiologies like vestibular migraine, stroke. Pathological head impulse. We know that patients with vestibular neuritis have pathological head impulse, but it can be seen in stroke patient. Nystagmus without fixation, we know that it is due to the peripheral, but it can be seen in central etiologies. The suppression, fixation suppression of the nystagmus, there is a pathway. If the central etiology doesn't involve that pathway, then it is going to mimic like a peripheral. In central etiology also is going to mimic like peripheral. So that these caveats we should remember. And with that, I will stop here. If you have any questions or doubts, you can ask me. You can put it into the chat box, or you can unmute yourself and ask me. And the part one of this talk was I have already shared the link in the chat. You can go through if you haven't seen. With that, over to you, Dr. Sriharsha. Dr. Sriharsha, uh, till he gets connected, if you any one of you have any questions, you can type in the chat box, or you can unmute yourself and ask me questions. Are there any questions? Somebody might be typing, so I'll wait. So meanwhile, I'll just tell you that in the next talk, it is going to be so interesting because I have compiled all my central vestibular cases, and I have compiled it into a presentation where I have divided into saccadic abnormality, pursuit abnormalities, optokinetic abnormalities, and nystagmus, varieties of nystagmus, head impulse test. What are the interesting things? So I request all of you to please attend the, please like follow this particular Facebook page, Sahasra ENT Foundation, and even I keep posting it my on my Facebook. Many of you are my Facebook friends, so I request you to follow that, and then I'll be presenting a central. This series is for central, so if any one of you have questions, we can take the questions. Yeah, Dr. Devi Prasanna. Uh, oh, you are like 1 second. I'll try whether I can unmute you.
Thank you, sir.
Yeah, yeah.
Very nice talk, sir.
Thank you, thank you.
Very nice talk, sir. Sir, I had put a question in the chat box. The importance of Romberg's test and Underberger's test in vertigo patients.
Yeah. See, Romberg's test, if you see, rather than calling as Romberg's test, we should start calling tests of sensory denial. So if we look at a patient, a person, suppose a person is standing with eyes open, then the patient has visual cue. First thing what we do in firm ground, like firm surface, that we ask the patient to close the eyes, and that is actually a test of proprioception. Romberg's test is ideally we ask the patient to stand on a firm surface and ask the patient to close the eyes. That is a test of proprioception, that is position sense. Now, if the same person, if we ask the patient like to stand on a foam surface, then we are taking out the proprioception. We are trying to reduce the proprioceptive impulses. We can't negate it totally, but to a large extent, we are trying to reduce the proprioceptive impulses. And then, if we ask the patient to close the eye, if the eyes are open on a foam, it is that test doesn't mean anything. But if you ask the patient to close the eyes after standing on the foam, then we are truly negating both the three two components out of the three which are needed for balance. That is, we need a vision, which we have asked the patient to close the eye. We have reduced the proprioceptive impulses, that is by standing on the foam. Then we can truly call this patient as having vestibular ataxia. Of course, on the first day of neuritis, of course, we can find the patient that if you ask the patient even on a firm surface, you patient can have little imbalance. That can happen, but Romberg's test is the actual test of proprioceptive function, and if a patient has positive Romberg's, it conveys that patient has proprioceptive loss. It doesn't convey it is a vestibular loss. So it is mandatory. All neurootologists, I will request all of you to buy a foam, and you make it a habit that after checking the Rombergs, make sure that you ask the patient to stand on the foam and ask the patient to close the eyes. Another most important thing is, if the patient starts swaying even with eyes open, just with patient is unable to stand, or if you make the patient ask the patient to like reduce the distance between the stance, in then the patient starts swaying the balance, or there are tests of motor denial. Just now we have seen the sensory denial. Sensory denial, how we did: first we asked removed the vision by asking the patient to close the eyes, then we removed the proprioception by keeping the foam pad. Then we were testing the vestibular. But now I will tell you about the motor denials. Uh, the patient, suppose, is standing with a wide base stance. Ask the patient to reduce the stance, reduce the distance between the two legs. That is first provocative test. Then, if still the patient is able to stand, then ask the patient to stand in the tandem fashion. And many times I have seen in patients with stroke, mild strokes in cerebellum, they are able to stand with legs like close to each other. But in a tandem tandem fashion, they are not able to stand. Even with open eyes, they will start swaying. That is, swaying is okay. Swaying is natural for us. But if the patient falls, patient is not able to maintain that stance, young patients, then it, and the next test after that is, after motor denial test, is ask the patient to stand on one leg. If one leg the patient is able to stand for 5 seconds, you can say that the patient has intact all the vestibular system, the extrapyramidal, pyramidal, and system, and other leg also the patient should stand. So these are the tests of escalating sensory denial, is that Romberg's and that type of test, and escalating motor denial test. So each test has its own neuroanatomical localization. If a patient is unable to stand with eyes open, it is definitely central. If a patient is not able to stand with eyes closed on a firm surface, think of first thing, that is actual Romberg's positive. When a patient is not able to stand with eyes closed, eyes open, that we should not call it as a Romberg's positive. Romberg's positive is a classical sign on a firm surface. If the patient closes eyes and then starts falling, is a Romberg sign positive. So, I hope I clarified your doubt.
Yes, sir.
Yeah.
What about Unterberger's test?
Unterberger's test is a very useful test, and unfortunately, I have seen in different forums that this test is told that it is not so important test, and it is not, doesn't have any value in differentiating and all. But believe me that it is such a valuable test. We all know that it is valuable test in neuritis. The patient will start pivoting towards the side of the neuritis, nerve involvement. But even in stroke patients, I have done Unterberger's test, and it has a meaning. It has it can cause again the same thing happens in case of central etiology. Patient can deviate to the same side of the lesion or on the opposite side of the lesion, because it is central etiology. Central pathways, they can cross to the other side, and it has a lot of variations can happen in case of Unterberger. It can come as normal. The patient can pivot to one side, patient can pivot to the other side also. It is something similar to the head impulse test. Head impulse test is usually normal in patients with central etiology, but it can be positive on the same side, it can be positive on the contralateral side. So we can't say that Unterberger's is absolute test, and unfortunately that is told in different forums. But I found I find that it is a very good test to at least decide asymmetry. See, whether it is central or peripheral is a different question.
Yes.
Whether there is a vestibular asymmetry or not, you can decide based on the Unterberger's test.
Even in BPPV patients, many patients show a positive Unterberger's test because of the imbalance.
Okay. Yeah. Honestly, I didn't. I should start after your observation. I should start observing this, because the time is so limited not to examine the patient and all. So we have to look for central signs also. But yes, I will definitely start looking at the patient, and I agree with your finding. It must be there, especially patients who develop little vestibulopathy secondary to BPPV. It can cause canal paralysis, it can cause canal jams. So these patients, we can look for the Unterberger's, and these are the patients whom we should refer for the vestibular rehabilitation. For example, in a PPPV patient, if you do repositioning and still the Unterberger's is showing some pivoting, that indicates that the patient needs some vestibular rehabilitation therapy to bring back his balance.
Yes, sir. Thank you, sir.
Yeah, yeah.
Thank you. Nice to see you after so many days. No? Long time.
Yeah. But now I'm planning to make it regular. There are so many activities which were going on. But let us see. We will continue this talk on central vestibular disorders. And I don't know how I couldn't see the comment what you posted in the chat because is it there? Did you post in the chat box?
Yes, it's there in the chat, common chat box. Yeah, there are so many comments here, sir. What is your opinion about light pupilla? There are so many comments here.
Oh
There are
my
so
God,
many.
I'm not able to see. One
Sir,
second.
I will read out the question, sir.
Yeah, please read out for me because Dr. Sriharsha, I think he's busy. Yeah.
Yeah, I'll read out the question, sir. I was actually listening, so since you both were discussing, I didn't interrupt you.
Okay.
So questions will start from the first one, sir. So already Devi Prasan sir's questions you have answered. Next question is what are any other vascular abnormalities are associated with hearing loss?
Vascular, vascular. First thing is, I during my talk I told that hearing loss can happen in patients with a labyrinthine artery infarction. It can happen in anterior inferior cerebellar artery infarction. Hearing loss, other vascular anomalies. Uh, no other, like these are the two prominent ones in which the hearing loss can happen, like anterior inferior infarction and this thing. Even bleed can. Yeah. Yeah. So
So next question. When would you decide that a patient definitely requires an MR for definitive diagnosis?
see, it's very important to look at the context, and we have to see like case to case basis clinically. There are two things: one is symptoms and second is signs. Based on the symptoms, if the patient has monosymptomatic vertigo or only vegetative non-localizing symptoms, then we have to rely on the signs. Then the signs will come into the picture. But if a patient has clear-cut symptoms like slurring of speech or numbness, and in those cases it is clear-cut, we can go ahead with the imaging. But in patients who have only signs which can be seen, symptoms which are seen in both central and peripheral, like vertigo, vomiting, nausea, and other like tinnitus, we cannot differentiate this hearing loss. We cannot differentiate whether it is central or peripheral. In that case, what we can do is look for the signs. If it is acute vestibular syndrome, doing hints plus examination is very important. If the head impulse test is normal, if the nystagmus is like gaze evoke type of nystagmus, or nystagmus which is not getting suppressed on fixation, then new these other varieties of nystagmus, which like rebound nystagmus or this Brun's nystagmus, these other varieties of nystagmus if we see. And the third is torsional skew deviation, then new onset acute hearing loss, or there are any other like symptoms, signs like pronator drift. I see in my practice that this pronator drift sign is so important that we should ask the when we ask the patient to outstretch the hands and ask the patient to close the eyes. If the patient has subtle pyramidal deficits, it will show up in the, not only pyramidal deficits, it's a very good sign to test cerebellar function, extrapyramidal function, proprioceptive function. So these are the clues which will help in that particular scenario. So it is not again, it is not a very straightforward answer that this, if you see this particular thing, you go for imaging. We have to, according to the situation, we have to decide. For example, a patient is presenting with positional vertigo. Patient has a typical nystagmus of BPPV. Then I had similar patient had downbeating torsional nystagmus and on lying down. I did Yakovina maneuver 3 times. The patient was not getting repositioned. A patient was not recovering. Then I decided, yes, I should do imaging, and patient was actually having vestibular paroxysmia. Then a patient who presented to me with positional vertigo, When he was sitting and talking to me, it was classical. I diagnosed him. I thought it is a BPPV. He's having positional vertigo. I took him to examination. He was not able to stand. He was not able to do this tandem walk. He had finger nose ataxia. So he was a case of cerebellar infarction. So it is very important to assess a case comprehensively. First, take a good history, then check the patient's all the signs, especially the hints plus in acute vestibular syndrome and other signs, ocular motor signs and all, and then come to a conclusion whether the and again the follow up is also important. For example, if you are treating some patient for as a with some provisional diagnosis and the patient is not recovering, that is an indication for imaging. So these are the contexts where we should do imaging.
Sorry, I forgot to unmute. What is the role of beta suck in symptoms of central vertigo?
See, currently there are no studies which suggest that we should it has a role, but it of course it has a role in symptomatic management. There are ongoing studies for of beta histine in patients with there is one study which says that it helps in rehabilitation, like it acts like a vestibular rehabilitation, and it helps in vestibular compensation. So time will help us to know that how much it is helpful in central causes. But by and large, if we look at the central causes, we have to treat the give the specific therapy in central causes than the symptomatic therapy. For example, if a patient has vestibular migraine, treat the underlying migraine unless we start the prophylactic therapy. Patient is not going to improve just with the symptomatic therapy. If the patient has suppose paroxysmal symptoms after a stroke or after a demyelination, that same patient is not going to respond to the beta histine. We have to give carbamazepine for that symptom. So, if a patient has vertigo related to thiamine deficiency, unless the patient receives thiamine, the patient is not going to improve with any of these symptomatic therapy. So, it is very important even in peripheral etiologies, it is very important to treat the specific diagnosis than the symptom. Just a symptom control, what usually seen in practice is somebody starts 8 mg twice daily, then it goes to another person, then he makes it 16 mg BD, then it is made 24 mg twice daily, then somebody adds another. See, this symptomatic therapy, there is like it will just suppress the symptom. So, most important thing is, of course, symptomatic therapy is also important because, for example, in patient with neuritis or a patient with acute vertigo, because even with stroke, first few days patient is very much symptomatic, so we have to give some suppression to give calm down, because otherwise that will trigger so much anxiety that the patient can go into triple PD. So symptom control is also important, but keeping the patient lifelong on medication without specific diagnosis is not recommended.
So, sir, one more commonly asked question. What is your drug of choice for vestibular migraine?
Uh, I generally treat vestibular migraine like a migraine, like a pure migraine, because as a neurologist, I see migraine, and the drug of choice is beta blockers. Because generally they are safe unless the patient is asthmatic. If even if patient has asthma, I use bisoprolol, I use nebivolol, and I find that patients recover very nicely with beta blockers. Unfortunately, flunarizine is not available here freely for like in my practice, so I don't use much of flunarizine. I use magnesium in every patient along with beta blocker. So first line of therapy what I give in patients with vestibular migraine is beta blocker with magnesium. Beta blocker if there is no contraindication.
Can we combine magnesium and flunarizine? Is it a good combination?
Yes, magnesium can be combined because see, it is a supplement. It can be combined with like any of these migraine preventive therapies. I don't think there could be any contraindication because flunarizine is a calcium channel blocker and it can be combined with magnesium.
Uh, from next question from Chandrakanta Jain. What is your opinion about light cupula and what is the treatment protocol for light cupula?
Yeah. So, Dr. Chandrakanta, thank you for asking this question. So, basically, in cupular syndromes, today the theme of our talk was central vestibular disorders, but I would answer that. So, cupular syndromes, what happens is normally what happens is the endolymph and the cupula has same specific gravity, but one like thing can become heavier as compared to others. For example, in endolymph becomes heavier than the cupula in BPPV. For example, if there are particles in the endolymph, that becomes heavier. So in case of light cupula, the endolymph is normal, but the cupula becomes lighter. So there are. I think you asked what are the etiologies and what should be done. So light cupula, it can present with positional vertigo. Patients can be one of the etiology is vestibular migraine, and there are other etiologies also, but it can present like positional vertigo because the normally the semicircular canals are not sensitive to gravity, but it becomes sensitive to gravity because of the change in the specific gravity of the fluid in relation to each other. The cupula with respect to endolymph, the specific gravity changes, then that makes that causes the ampulofugal or ampulopetal flow, and it can lead to the nystagmus, positional vertigo, and nystagmus. And a null point is a very useful thing to diagnose cupulopathy because how to differentiate cupula versus cupulopathy versus the canalithiasis is in canalithiasis there will not be a null point, the nystagmus will be fatigable, but in cupulopathy the nystagmus is not fatigable. Once the cupula is shifted to one side, it is not going to happen that the in case of canalithiasis the particles settle down, so that's why the nystagmus and symptoms settle down, but the cupula the deflection remains same in that particular position. And it is how you can document cupulopathy is by slightly slowly changing the head position and trying to find that null point where the nystagmus disappears. I hope I answered your doubt. But I don't know more causes about the cupulopathy, light cupula, than apart from vestibular migraine. It can happen transiently in case of alcohol, but as we see like in practice, we see occasionally this cupulopathy is not that like commonly I see, because I generally see patients with vestibular migraine. They do have this positional vertigo, and they might have this patients they might have this positional nystagmus which is not fatigable. I have seen couple of cases where it was not fatigable, and these were the cases of cupulopathy because of vestibular migraine. But apart from that, I don't have any experience of any other etiology causing light cupula.
So that's all, sir. Questions from the chat section. So if any of the audience, you can unmute if you have any more questions, or else we can close the session. What is the treatment protocol for cupulopathies?
For
Cupulopathy, light cupula.
See, treatment protocol. See, depends on the. We have to just first see the what is the underlying cause, and see, honestly, I haven't like basically you have to treat the underlying cause. For example, one patient I mentioned. In that patient, I thought it is vestibular migraine leading to cupulopathy. When I treated the patient for vestibular migraine, and this patient had apogeotropic variety of nystagmus. Actually, it was looking like apogeotropic lateral canal BPPV. I did Zuma maneuver, but the patient was not improving. And when I treated with migraine prophylaxis, patient improved. So it is not the in light cupilla, it is not a maneuver which is going to help. It is I think that we have to treat the underlying etiology. Unless we treat underlying etiology, and the second thing is habituation exercises might be helpful. Honestly, I have to read an article about cupillopathy because I haven't gone into the depth of cupillopathy. Maybe in some of our talks, I can discuss about light cupilla syndrome.
That's also the questions for now.
Yeah, yeah.
A small request. Can we have one talk on persistent postural dizziness?
Yeah, definitely. We will keep it next talk. We can keep it.
Yeah. So this is one very least. I mean, not many are actually aware of this particular diagnosis.
Okay, okay. No worries. We can keep it next talk because I have a presentation even ready also. So next talk we can keep on that, or we can finish this particular central science and we,
Yeah,
however you say.
after central vestibulopathies, we'll have one webinar planned.
Yeah, because it is a very common disorder, triple PD, and I have around currently now 200 cases of triple PD. So in my registry, it is something which bothers the patient a lot, and it's very important to create awareness about that.
Yes.
So we can have that, no problem.
Sure, sir. Thank you, sir. I think you're in India, sir, right now?
No, no, I am here in Dubai.
You flew back. Okay, okay. So because I was seeing your posts and I think you
Yeah,
were.
those are a few days ago. They like I couldn't post, so I
Okay.
did posts.
Okay, sir. Thank you once again, sir. We'll see you again in the next session.
Yeah, yeah. Thank you so much. Thank you, everyone. Bye.
Bye.
Bye, sir.